My name is Matthew Hecht. I'm a volunteer. I'm with Bristol Myers Squibb. And we're very lucky here. I wanted to welcome you all to the workshop on male sexual health after transplant. I will be your moderator this afternoon, and I'm looking forward to hearing from our guest speaker, Dr. Mohal. We will be recording this session, so if you could please use a microphone if you do ask a question for those who aren't able to attend the meeting. And at the end of after Dr. Mohal's presentation, there will be time for Q&A. So please join me in welcoming Dr. John Mohal. Dr. Mohal is the director of the Male Sexual and Reproductive Medicine Program at Memorial Sloan Kettering Cancer Center. The Male Sexual and Reproductive Medicine Program is devoted entirely to the care of men who have suffered sexual difficulties or fertility problems as a result of their cancer or cancer treatment. And thank you, Dr. Mohal.
My pleasure. So it's my pleasure to be here. I'm a urologist. Been in practice for 18 years, and for about 16 and a half of those years, I've done nothing other than this. Okay, so I don't do benign prostate disease. If you've got a prostate problem today, it's not the day to ask me a question. If you've got kidney stones, I'm not the guy. But there's nobody in this room who knows more about the penis than I do. So if you've got a penis question, I'm your man. So I think you're aware that the concept of survivorship is that not alone should we be focusing on treating and curing your cancer, but we should address those issues that arise as a consequence of your cancer diagnosis and your cancer treatment. Okay? And that's essentially survivorship. So I'm a survivorship physician. There aren't that many places in the country. I presume most of you are from the tri-state area. Anyone from like way far away? No? Okay, right. That's pretty far away. There are very few centers that have the ability to hire somebody who does just what I do for a living. I mean, we have 3 nurse practitioners, we have a psychologist, myself, a fellow. It's a huge, huge undertaking, and I'm very proud to work at Memorial. So how does cancer cause sexual problems? Well, the very first thing is any stressor in your life is going to put you at risk as a man for having sexual problems. Diagnosis of cancer is a stressor. Adrenaline is the world's most potent anti-erection chemical. Bad day at work, bad week at work, you hate your job, you hate your wife, you've no money. That's a problem. Okay? And the women in the audience know very well that men are only as good as their last erection. So if your last erection wasn't good, the next time it's going to be worse, and the next time after that it becomes a spiral. Okay? So psychologically, the diagnosis of cancer is a problem. The classic example is men get diagnosed with prostate cancer, and in the time between their diagnosis and them having surgery, let's say 3 months, their erectile function changes dramatically. Surgery, probably not relevant to you. In the pelvis causes problems. Chemotherapy, hormone therapy, radiation are notorious causes of male sexual health problems. Now, I think you're all familiar with ED. You can't turn on the TV without learning about erectile dysfunction. Your 11-year-olds probably know what ED is, looking at Viagra, Cialis, and Levitra ads. But there are many other things, and my practice is devoted to sexual health. It's not just about giving men a hard erection. It's about looking at the totality of sexual health and improving couples' sexual satisfaction. Now, what about transplant? There are 3 areas that we're going to talk about today, and I can give you a flavor for this, and hope this will last about 30 minutes, and then we've got time for questions. But these are the 3 areas that you need to know about. As I look around the room, the age is pretty discrepant. Okay, there's some younger people and there's some older people. Some of these may not be relevant to you, but some of them may be relevant to you if you go to a workshop or a support group elsewhere, if you have a family member or friend who's going to go through transplant. These are things you need to know about. Infertility, low testosterone, huge issue. We have a huge number of referrals from the transplant service at Memorial Sloan Kettering over to us, and very common that we see men with low testosterone. And then sexual problems. And we will focus today, during the lecture part at least, on erectile dysfunction, although I'm happy to answer any questions you have about sexual function. The testicle is the word that means the 2 organs that sit in your scrotum. The testis and the epididymis, which is a little gland that lies behind the testis where sperm learns to swim. That's the testicle, that complex. The testis has 2 types of cells in it. It's got sperm-producing cells in these tubules, called the seminiferous tubule. 85% of a testis is sperm-producing tissue in a normal testis. 15% of it are these cells here, Leydig cells, which make testosterone. 95% of our testosterone is made by the testis. 5% comes from our adrenal gland. Very analogous to estrogen production in women. The vast majority comes from the ovary. Some of it comes from the adrenal gland. So that's just anatomy 101. Any of you transplant physicians? Good. They should be very embarrassed at the paucity, the absence of literature on sexual and fertility health in the transplant population. It is abysmal. There is practically nothing in the transplant literature. And if you look at some of these references, you're going back to decades ago. There just isn't much literature. Cancer doctors are focused on one thing, whether they're prostate cancer, bladder cancer, breast cancer, hematogenous malignancy cancer people. They're focused on you surviving. They're not trained in discussing with you about quality of life issues. Okay? However, at major medical centers, they do have the option of sending you to see somebody who does do that for a living, and it is your responsibility to communicate to the physician, this is important to me, where do I go? You cannot wait for the cancer physician to bring this up. The vast majority of times, it will not happen. That's true for men. It is absolutely true for female sexual health. So if we just look at this is a paper from Bone Marrow Transplant, a very famous journal, 1996. 50% reduction in the volume of the testis after high-dose chemoradiation. Okay? I just told you that testis makes sperm and the testis makes testosterone. 50% reduction in the size of the testis, not necessarily a 50% reduction in your testosterone, but you can imagine a significant negative impact on your testosterone production. 2006, 25% of autologous, greater than 60% of allogeneic transplants are performed in patients younger than 40 years of age. Why is that important to me? Fertility. Now I'll make a caveat statement here, and that is, if you were a physician, I'd say to you, you can't look at a patient and presume they are or are not interested in fertility. I work in Manhattan. I've got plenty of couples. 65-year-old man, 35-year-old wife. He's interested in having a family with that woman. I've got plenty of 35-year-old gay men who have no interest in starting a family. So the age itself does not equal interest in reproductive health. Moving on to 2007, Journal of Clinical Oncology, probably the most famous cancer medical journal that exists, JCO. Majority of patients are infertile after stem cell transplant because of damage to the germ cells, so those sperm-producing cells. Over a 10-year period, 4 out of 137 patients in the study were able to conceive, and 3 of the 4 used assisted reproductive techniques, in vitro fertilization. Okay? So you start to get a flavor that this is an issue. If you look just at the red box, hypogonadism is the medical term for low testosterone. And if you look at various age groups here, you'll see very high rates. Yeah, it's on. It's just not working. I think the battery's probably dead. Very high rates of low testosterone. If you look at the bottom, 79% of men had germ cell dysfunction. All were azoospermic. No sperm in the study. And 89% of men had Leydig cell dysfunction. 20% had low testosterone. Okay? So at least 1 in 5 men are going to have testosterone problems. And when those patients get sent over to us, it's about 2 in 3 men who have testosterone issues. We'll talk about testosterone in a minute. This is probably not completely relevant to you, but if you have surgery in your pelvis, just because you're 62 years of age and you're at a transplant conference doesn't mean that you haven't had a radical prostatectomy for prostate cancer or that you're not going to have in the future. But any surgery in our pelvis for a man or a woman puts you at risk for having sexual problems. Radical prostatectomy, radical rectal surgery, radical hysterectomy puts you at risk for sexual problems. What about radiation therapy? Well, the only form of radiation that really causes significant erection problems is radiation to the pelvis, prostate cancer, rectal cancer, or to the testes. And some transplant patients, some hematologic malignancy patients end up getting radiation to the testes. You do not need a lot of radiation to the testes to cause permanent sterility. Very low doses to the testis will cause a problem. Nerve damage, direct effect of radiation therapy. The arteries that supply the penis, direct effect of radiation on them causes damage. And then the muscle in the penis. The penis is very, very close to all the other organs. The pelvis is a very tight space with lots of things pushed in there. It is impossible to avoid the penis from radiation if you radiate the pelvis. Chemotherapy causes damage to the testicles, leading to a reduction in testosterone production. Now let me say something very important to you. Testosterone is not an erection chemical. If you have ED and you go and you have low testosterone, and the doctor says, I'm going to put you on testosterone, it is not likely that's going to help your erections. It might help your nighttime erections. It might help your libido. It might help you achieving orgasm. It might even help your intensity of orgasm. But it is not, generally speaking, going to get you harder or sustaining better. Okay? This is a common problem in this country where patients go into the doctor with erection problems. The doctor puts them on testosterone. 3 months later, the patient says, my erections are still bad. What's going on? Testosterone is not a good erectogenic hormone. Chemotherapy attacks the most rapidly dividing cells in the body. That's how chemotherapy works. The most rapidly dividing cells in the body are cancer cells, irrespective of what type of cancer you have. Okay? The most rapidly dividing normal cells in the body are in the testicle. Okay? Those sperm-producing cells, we produce as a man 50,000 sperm per hour of our lives in healthy men. You can imagine how hard those cells are working. They incorporate the chemotherapy into their DNA, they die. Okay? It depends on which chemotherapy agent you have, the dose, and the duration of the exposure, what the outcome is going to be. Just looking at some more stem transplant literature, if you look at this paper from Psycho-Oncology 2009, sexual dysfunction is one of the most prevalent and persistent problems after stem cell therapy. Humphreys in 2007, half of the patients never had a discussion with a healthcare provider regarding sexual function at any point. I'm not going to ask you to put your hand up, but I would surmise that the vast majority of you have never had a conversation with a transplant doctor that lasted longer than 30 seconds about your sexual health. Usually it goes, I've got a problem with my erections. Oh, Dr. Jones does that. Go see Dr. Jones. Patients who did have a discussion within 3 years of treatment had fewer sexual function complaints. It is uniform in the medical literature that if a doctor has a discussion with a patient about quality of life, that the patient's dissatisfaction level drops and regret level drops, irrespective of the cancer. No matter what the outcome, the fact that we engage with patients as a physician tells the patient, we believe this is an important part of your life, we understand this is a problem, and that alone is a therapeutic maneuver. Decreased interest in sex, orgasmic and ejaculatory function are frequent concerns besides erection problems. This is from the Global Study of Sexual Attitudes and Behaviors. It's a Pfizer-sponsored study. I'm sorry that the numbers don't appear, but this is men and women coming out of their family doctor's office, get asked a questionnaire. And one of the questions was, over the last 12 months, has your doctor asked you about your sexual health? Okay? Men and women, all far right-hand side, North America, 12%. 12% of men and women said, yeah, my doctor asked me about my sexual health in the last 12 months. We do a really poor job as physicians at discussing sexual health. That shouldn't be a surprise to you if I tell you that the average physician gets 2 hours of sexual health education during medical school. They get more training in tropical medicine than they do in sexual health. And sexual health in most medical schools includes adolescent gynecology, sexually transmitted diseases, and all the stuff that we've talked about today. So how can we make a physician comfortable if we don't train him or her? And they go into practice, they don't know how to take a sexual history, they're not even comfortable. You cannot presume if you're a man and you go to see a urologist, you can't presume your urologist is comfortable talking about your penis. Many urologists are very uncomfortable. They do urology to operate, not necessarily to talk to you about sexual problems. Here are the barriers. There are patient and physician barriers. Embarrassment, shame on behalf of the patient, ignorance about what's normal. There aren't a lot of normals. People come in and say, well, what age should I stop having sex at? If you're interested in sex, you continue having sex until you die. I have 2 93-year-old men in my practice, for goodness sake. Cultural, religious beliefs, and just general discomfort about the topic. But on the other side, we have physician issues. Discomfort, lack of knowledge, personal bias, time constraints. Over the last decade, physicians have to see more patients in a shorter period of time. You go to see your family doctor, he wants to talk to you about your diabetes, your high blood pressure, your cigarette smoking. The sexual problems just get put off unless you bring it up. And when you bring it up, of course, he or she already has their hand on the doorknob and they're leaving the room. But doc, things aren't working that well. And they give you a sample. They never tell you how to take these medications. You fail. They never talk to you about it again. Okay? Let me just mention about this concept of personal bias. We're human beings as physicians. We routinely project onto our patients. That's true whether it's sexual health or cancer therapy or hypertension or diabetes. Okay? So we as human beings project. Our beliefs get projected onto you. Classic example is if you look at urologists and Cialis is the 36-hour ED drug, right? If you look at urologists who are 40 years of age and younger, they're routinely prescribing Cialis. Why? Well, of course everyone's interested in 36 hours, but the patient in front of you is 72 and his wife is 73 and they have sex 4 times a year. Right? So we project all the time onto our patients. This is an interesting paper from 1999, the American Family Physician, the top 10 medical conditions too embarrassing for patients to discuss with their family physician. I don't think it's changed that much, even with the introduction of Viagra drugs. ED was top of the list. What's interesting is that if you speak to patients, and this is published literature, if you speak to patients and say, why didn't you bring up your erection problems, Mr. Jones? 2/3 of them will say, I thought the physician would be embarrassed. We think the physician will be embarrassed. We as physicians send off vibes. You must start the conversation. There's a great cartoon, which I don't have here, which has a patient and a physician in an office, and they've got these these thoughts coming out of each other's heads. It's saying the same thing. I hope he brings it up. Okay? So you must bring it up. You must be proactive about your sexual health. We've come a long way from the 60s when we thought everyone had psychological problems. Implants in the 70s, penile injections in the 80s, transurethral prostaglandin, the urethral suppository in 1997, Viagra in 1998, the second sexual revolution, no doubt about it. Okay? Changed how we perceive sexual dysfunction. Who would have thought we'd ever see an ad on TV about erections? 2004, Cialis and Levitra, and the new kid on the block now is Stendra. This is the process of care model, the model that physicians are supposed to use for the treatment of erection problems. First line therapy, lifestyle modification. If you're overweight, get your weight in order. Diabetic, hypertension, dyslipidemia, get them fixed. Your cigarette smokers, stop. Okay, if you're not exercising, exercise. Medication adjustment, there are very rare medications that you stop that all of a sudden Bill Jones says, hey, I'm back. Very, very rare. Psychology input if there's interpersonal conflict. Oral agents, Viagra, Levitra, Cialis, Stendra, and then vacuum devices. Second line therapy is penis injections, and third line therapy is implant surgery, and we won't talk about that today. These are the pills, okay? Given the use of pills in the United States of America, it's extremely likely 9 in 10 of you have been exposed to a pill on at least one occasion. Okay, whether you have ED or not, men are using these pills. Viagra, Levitra, Cialis, and Stendra. Duration of action. So Viagra and Levitra are almost identical. They last about 12 hours. Definitely 8. Cialis, known in France as Le Weekender, lasts 36 hours. And Stendra is the short kid on the block. Lasts 6 hours. Okay? Speed of onset, however, Viagra, Levitra, take about an hour to kick in. Cialis takes much longer, and look at Stendra, 15 minutes. Okay? So Stendra is the new drug. It's getting a lot of traction at the moment. Food, sildenafil and vardenafil, Viagra and Levitra, big food effect. You have to take them on an empty stomach. Cialis, Stendra, no food effect. Side effects, Viagra is clearly the drug that gives the most side effects. But it is our barometer drug, because it is, for the most men, it is the drug that gives the best response. So if you come in and you want to try a pill, it's likely that the first drug you'll get in my practice is Viagra. Why? We like to give men the drug that's the best chance of giving you a good response. Here is the philosophy at Memorial Sloan Kettering. We always start at maximum dose. Why? We want to give you the best erection you can possibly get as quickly as possible. Why? The average man who is ED comes in to see me 18 months at least into his ED problems. The average man. Yes, we see guys who come in 2 weeks after they had one failure. That's uncommon. We get men coming in 10 years later, the vast majority, 18 to 24 months after the onset, erosion of confidence. We want to get that man the best response possible, maximum dose, and then you down titrate for side effects or if it really works well. Mr. Jones, you take the full pill. If it's fantastic, you take half a pill. If that's great, you take a quarter pill. You use the lowest dose that works for you. But we always start with maximum dose. Adequate patient's instructions. Viagra, Levitra. If you happen to be using those drugs, our patients always take it 2 hours before a meal. Stomach is empty before you eat. 2 hours before a meal lasts at least 8 hours. Mr. Jones, you take your dinner at 7, you take it at 5, you're good till midnight. That's the phrase that our patients leave the office with. Okay? You take the pill with a glass of water, it's in your stomach, it's out of your stomach, before you put food or alcohol in there. Why do I care about food or alcohol? They drop the dose and they slow the absorption. People come in all the time and say, it didn't work. They took it an hour after a big meal. Big steak, a lot of fatty food, the medication's stuck in the stomach, it never gets out of there. 4 hours later, it's still in the stomach. Okay? So 2 hours before a meal. Dinner at 7, take it at 5, you're good till midnight. Sexual stimulation required, Mr. Jones. Here and here. Can't go in the corner read the New York Times. Nothing happened, doctor. That's not how it works. We have to be sexually stimulated. That is why we've never had, in 22,000 patients at Memorial Sloan Kettering in my practice, over 15 years who've used these pills, we've never had a priapism. You see it on TV, 4 hours, call your doctor. Never happened with a pill. Okay? Because once you're not stimulated, mentally or physically, the chemical no longer works. Okay? Wait 2 to 4 hours before trying Cialis. It's a slower acting drug. There's a new kid on the block. There's daily Cialis, okay, which is also used for prostate disease, by the way, prostate enlargement. If you have high frequency of intercourse, 3 times a week or higher, or no predictability, I just never know what's going to happen. Daily Cialis is an excellent drug for you. In your blood, every minute of every day of every week. Really good for young men, single men, and really good for men who have psychological erection problems so they never fail. Okay? Stendra kicks in 15 minutes. There's really no instructions. It is impossible not to use Stendra properly. You pop the pill, 15 minutes later, sexual stimulation, generally speaking, you're ready to go. Follow-up visits. If you had high blood pressure, diabetes, or high cholesterol, your family doctor would say to you, let's get you back and let's talk to you about your blood pressure, your cholesterol level, and your sugar control. But I'll guarantee you, almost, that they won't say that to you with an ED drug. Right? So you go out, you use it, you're not sure you're using it properly, it's not responding very well, there's no follow-up. That is why 1/3 of men stop using these pills after 1 prescription, and 1/2 stop them by 6 months. Because there's no follow-up. It's a huge contributor to the attrition rate, the dropout rate. Headache, facial flushing, heartburn, nasal congestion, blurred vision, and muscle aches are the classic side effects. They are class effects. Yes, you may have less a headache with one pill than another, but they can occur with all patients. 2 to 3% of men drop out because of side effects. Usually the side effects are very mild and are very well tolerated and don't last very long. Let me make a couple of pointers. If you're a headache guy, if you suffer from migraine or cluster headaches, you have a higher chance of getting headaches. If you've got a sinus congestion problem, I've got a terrible nose, you're probably going to get nasal congestion. Now, you can take a Tylenol or an Advil with your Viagra to cut off the headache. You can take Afrin, okay, with your pill to cut off the nasal congestion. We would not advise you to use Sudafed because Sudafed is essentially adrenaline, anti-erection. So you don't want to take a pill by mouth that might negate your erection pill working. Blurred vision, double vision, change in color vision. For those of you who've ever used Viagra and you've been in a bright light scenario, kind of loss of color vision called the blue halo. Not dangerous, it just cross-reacts with an enzyme in the retina. It's very short-lived, it is inconsequential. For the women in the audience, Viagra, Levitra, Cialis doesn't cause heart attacks. There are 2 circumstances under which men should not use these drugs. 1, if they use or possess nitroglycerin medication for heart attacks, right? Number 2, if they can't walk up 2 flights of stairs briskly without getting chest pain, then they shouldn't be having sex. Sadly, that's the average amount of energy a man expends in the bedroom. Okay? So, other than that, you can use these pills. They're perfectly safe. Remember how they got designed. They got designed as an anti-anginal agent. They were used for chest pain. Viagra was introduced for chest pain in 1992, Pfizer in the United Kingdom. And they realized that men weren't giving the pill back at the end of the trial. And they looked into it, and they realized that these guys were saying, I'm getting better erections. And it took a man by the name of Ian Osterloh, who worked for Pfizer, 4 years to convince the management to study Viagra in ED. Multi-billion-dollar drug, all right? And it wasn't for Ian Osterloh, Pfizer wouldn't be as well off as they are today. Okay? Myalgia, which is the medical term for muscle aches, really occurs predominantly with Cialis. Okay? For those of you who take statins, it's not the statin kind of muscle ache. It's not the same cause. It's not muscle damage. It's just pooling of blood in the big muscles. Buttocks, thighs, lower back. Why? It lasts a long period of time. Okay? It occurs in 10% of men using maximum dose Cialis. 30 to 50% of men who walk into my office and say, I was given a drug by my other urologist or by my local doctor, and it's not working. 30 to 50%, it really is working. They're just not using it properly. Not on the right dose, not using it properly. Okay? And they can be re-educated. Penis injections, not invented by the Marquis de Sade, contrary to what public opinion is. Mosquito bite. The overwhelming majority of men will say, this is no worse than pulling a hair on the back of my head. Biggest problem, penis and injection in the same sentence. 90% of men get an erection good enough for intercourse. Rocket fuel. Okay? Very effective. Penis looks normal, feels normal. No effect on sensation, ejaculation, or fertility. Reasonable discretion. Fairly good spontaneity. Okay, yeah, you're going to be interrupted, foreplay, etc. You haven't taken the pill before, but really reliable, high level of confidence. Downside, high dropout rates. Okay, mainly related to the fact there's a needle involved. Okay, but very, very effective. Not covered by insurance for the vast majority of men, but in our practice, $85 gets you a bottle, and that will last you 3 to 6 months, depending on how often you're using it. About $2 to $3 a shot. Not bad. If you can't see your penis, you're not a good candidate. If you've got a shaky hand, you're not a good candidate. If you're on MAOI inhibitors, which is a very rare antidepressant, you're not a good candidate. However, if you're on blood thinners, you've got Peyronie's disease, which is penile curvature. If you've got a history of vasovagal attacks, I pass that when I get blood drawn. Or if you're predisposed to priapism, sickle cell disease, for example, you can still use it. You should be using it at a center that does this for a living. On any given day, we have 2,500 men enrolled in our injection program using injections. I won't go into huge details about priapism. Those ads on TV, 4 hours, call your doctor, okay, named after the Greek god of lust and fertility, Priapus, okay. This is a medical emergency. No, it's not cool. I say this all the time, it's a risk of priapism. With injections, people say, yeah, that's not a problem. Your penis starts dying after 4 hours, so it is a problem. Vacuum devices. This, I believe, was invented by the Marquis de Sade. Okay. Very, very effective at producing erection. Very low rate of sticking with it longer than 6 months. Why? The penis doesn't look normal. It doesn't feel normal. It feels cold to your partner. You have to wear a ring around the base of your penis. For most men, that's uncomfortable. It's cumbersome. You're a single man. Now you've got to carry your thing around with you, and Mary, I'll be right. So it's difficult to integrate into lovemaking, and that's the major reason. We talked about integratability of treatments in ED, and you have to be able to integrate into lovemaking. If you can't, you're not going to use it. Let's talk very briefly about sexual nutriceuticals. You turn on the TV at night, 11:30 at night, there's some guy with a white coat on, he looks like a doctor, he's an actor, and he's trying to sell you Enzymes or Enorex or something that makes your penis bigger, you're going to last longer, and you're going to be as hard as the wall, right? It's a multi-billion-dollar industry with zero regulation. Absolutely no FDA regulation. They can tell you anything they want. 95% of our patients are cured. It's complete rubbish. No trials. Okay? You've no idea what's in these products. Okay? 30% placebo response rate in ED drug trials. So 30% of men using a sugar pill in the Viagra, Levitra, Cialis trials, after 1 month said, I'm better. Attribute to the fact that every man has a secondary psychological component to their sexual problems. Okay? Even if you're physically based, there's a secondary psychological component. Some of these products contain testosterone, DHEA, androstenedione. You need to be careful, particularly if you've got prostate cancer. And many of them now, we know, contain Viagra, Levitra, Cialis. Low dose. get the facial flushing, get the nasal congestion. This stuff is really working. This is great. Boosts your confidence. All of a sudden you feel better. Okay? $39.99 money back guarantee. The women in the audience know how often do men ever return anything that doesn't work. Okay? Billion-dollar industry. So, understand how ED occurs. See a physician early if you have it. PD-5 inhibitors, Viagra drugs are safe and effective. Understand how to take the medications. There are other treatments available. Low testosterone is a common problem. As we age, 15% drop in our testosterone per decade of life. Without a transplant. With a transplant, remember, testis damage, more likely to have low testosterone because of chemotherapy. It is uncommon in my practice that I give testosterone to a man for a sexual problem. I give testosterone to a man for other problems because testosterone is one of the most important hormones in the body. I'll give you 3 important examples. It's essential for bone density. Men with low testosterone very commonly have osteoporosis, or the stage before it called osteopenia. Number 2, low testosterone is associated with diabetes development. You need testosterone to control your sugar. If you're diabetic, your hemoglobin A1C will be higher if your testosterone level is low versus if your testosterone level is normal. And number 3, and there's compelling evidence to show this, low testosterone causes premature cardiovascular events. And that is heart attack and stroke. So for those 3 reasons, we use testosterone. There are many, many, many medical conditions that are associated with low testosterone. The one that you need to be worried about is the one at the bottom, testicular radiation or chemotherapy. These are the classic symptoms of low testosterone. Low sex drive, decreased energy, afternoon fatigue, loss of muscle, putting on fat, decreased endurance. I walk up 3, 4 flights of stairs. God, my legs are like lead, Doc. 5 o'clock in the afternoon, I got to take a nap. Classic examples. Okay? The other things are anemia. Now, you've got another reason for having anemia, of course. A low PSA. Men with really low PSAs, we always think, does his testosterone level low or not? And then it can, when it's very low, impact upon erections. Now, I put this up. This is a little bit of a sensationalist slide. Shocker index is high. This is premature death. The Veterans Administration look at men with testosterone levels. If you just look at the orange bar, men with testosterone levels lower than 200, normal 300, 800, premature death in the VA. Okay? Low testosterone is bad. Okay? There are many men in this country who are on testosterone who should never be on testosterone. They don't have a testosterone level. It's estimated that 20% of men in America who are on testosterone have never had a testosterone level checked. Where are they going? They're going to bad doctors or to anti-aging clinics. Come to Manhattan, go to anti-aging clinics. We'll charge you $5,000. We'll make you look young and beautiful again. Okay? It's a real charlatan situation. If you're having your testosterone level checked, please get it checked before 10 o'clock in the morning. It's highest in the morning, lowest in the afternoon. It just has a natural circadian rhythm. The standard is to check it at its peak. How do we replace testosterone? There are no pills. There's a pill in trials at the moment, and I believe we will have a pill sometime probably in the next 3 years. Who hasn't seen lowt.com on TV at night? There are now 5 gels. Androgel, Testum, Axiron, Fortesta, and the new kid on the block, Vogelexo. There are patches. There are shots. There are shots that you take every week, and there's a shot that lasts 10 weeks, and there are pellets. It's beyond the scope of this lecture to start going into the pros and cons and risks and benefits, all of those. They all elevate testosterone very, very effectively. In the average man with low testosterone symptoms, testosterone replacement therapy is safe and effective. Let me spend 15 seconds. You've probably seen on TV, lowtlawyers.com, right? There was a paper published in November of last year and another one in February of this year suggesting that testosterone supplementation causes heart attacks and strokes. The medical community has written letters to the editors of those 2 journals asking for those papers to be retracted. So flawed were they. They fly in the face of 20 years of research showing that low T causes heart attacks and strokes, and getting a man on normal T is protective. So no one in the field who does this for a living has changed the way they prescribe testosterone. Bad science can hurt people. Okay? What are the side effects? Well, if your testosterone level goes up a lot to your level when you were like 18 years of age, you can get acne. Interestingly, most men don't get acne on their face. They get acne on their back. We get phone calls, I got acne, it's a sign that your testosterone level is normalized. We need to kind of modulate your testosterone level. Polycythemia is the medical term for high hematocrit. You're a transplant patient, I'm sure you know what your hematocrit is, red blood cell count. When your red blood cell count goes too high, your blood becomes viscous. It puts you at risk for clots. That number is 52%. I have to tell you, it's very unusual for us to see a transplant patient with low testosterone who goes on testosterone who ends up getting polycythemia, because most of you guys are already anemic. Okay? In fact, some of our transplant physicians, including Ann Jakubowski, will use testosterone-like products to boost testosterone and boost red blood cell counts in men who have a normal testosterone level. They're doing it for one reason only, to get rid of the anemia. Gynecomastia, the medical term for breast enlargement, breast tenderness, nipple tenderness, is related to estradiol. Very simply, testosterone gets broken down to estradiol. The higher your testosterone level, the higher your estradiol level. If your estradiol level goes too high, you start getting breast tissue development. Okay? Cardiovascular disease, we talked about prostate cancer. I'm happy to answer a question about prostate cancer. Testosterone supplementation does not cause prostate cancer, and if you have prostate cancer, in the majority of patients, you are a candidate for testosterone supplementation. Check your T levels before transplant. It is very, very uncommon that that is done. It is tremendously helpful to me if I know where you started when you come in to see me 2 years later with the low testosterone. Recheck your testosterone level 6 months after completion of chemotherapy. What is the impact of chemotherapy? If your T level is low, recheck it. We never base treatment on a single testosterone level. If your testosterone levels are low, you should get a bone density x-ray. Why? Low testosterone is associated with osteopenia and osteoporosis. It's important we know where you start off. We have a staggering incidence of bone density loss in our transplant patients. If you're on testosterone replacement therapy, you need to check your testosterone every 6 months. Just like you get your blood pressure checked if you're on antihypertensive pills, just like you get your cholesterol checked if you're on statins, you need your testosterone level checked. Okay? This is not just an aspirin. These are real drugs, and we need to monitor your testosterone level. Check your hematocrit, check your estradiol, and check your PSA levels if you're over 40 years of age. Finally, we don't have too many young people in the audience. If you're going to have chemo and you're still interested in having a family, bank sperm. You must bank sperm beforehand. No attempt at conception for 12 months after chemo radiation because of DNA damage. You need to wait at least 12 months and have protected intercourse for the duration of that time period. There is a high rate of infertility. I gave you a smattering of the literature out there. Very high rates of men with no sperm. Semen, yes, but no sperm. And recheck your semen analysis somewhere between 12 and 36 months after completion of treatment to see has any sperm returned to your semen. 3 years is ideal, but if you're older and your partner's older and you're in a rush, wait at least 12 months after treatment before doing that. I'm not talking about women. Men are simple. It's pretty much an on or an off switch for most of them. Women are much more complicated. If you're interested, next door Jean Carter is talking about that. This is my last slide. Let us not focus solely on adding years to life, but also pay attention to adding life to years. Thank you very much.
Doctor, you were spot on hematologists, oncologists, the great work they do, they don't address that. So I had to go to an endocrinologist, which really was the key to looking at all that stuff for the testosterone and bringing it up and some other things. So that's for benefit of everybody here. You can't get that. You gotta go to a specialist, I think. I mean, that's my success.
Well, the first, I'll say this again. The first thing is that you need to communicate to your treating physician, this is important to me, and there's a problem. Okay? I think most of them are going to refer you elsewhere. They're not going to resist that. They just don't want to deal with it themselves.
The other question I had is they put me on a drug called Megace to increase my appetite at the time, and I understand that's a female hormone, and that really degraded my this whole business of ED and testosterone. Could you comment on that?
So there's not a lot of literature on megestrol acetate, it's called Megace, and what its negative effect is. Generally speaking, anything that's the opposite of testosterone, so estrogens, megestrol, are not good for your sexual function, generally speaking. Okay, now it depends on the dose, depends on the duration you're on it, et cetera, et cetera. So it becomes a risk-benefit ratio. Which is the bigger threat to your life, threat to your quality of life? The appetite issue, losing the weight, sexual function. There's no evidence to show that Megace has a permanent effect on your sexual function. So it may be that you might need to be on this for a period of time, get things ramped up again from the appetite standpoint, and then wean off it, and then get back functioning. In the meantime, there may be ways that you can boost your sexual function while on Megestrol, by seeing a urologist, for example. Endocrinologists are very good at hormones. They're not very good at sexual health. So I would not necessarily have your endocrinologist be managing whatever erectile problems you would have, etc. Thank you for your question. Any other questions? Testosterone?
Just in general after a transplant.
Yeah, there isn't really a general. There really isn't a general. It is very, very problem specific. So it's fertility, sexual problems, you should see your urologist. If it's hormone, testosterone, you can see an endocrinologist. But most urologists, a significant part of the practice, 30% of my practice is low testosterone. Most urologists will deal with testosterone very well. Okay? But there isn't some general physician who got... Now listen, Memorial has survivorship nurses in transplant who will triage you, patient, and guide them to the appropriate expert. Okay? That really doesn't exist in the community practice. Yes, sir.
My question is, what are some of the most offending drugs that you can take that would affect erectile dysfunction that are being given to transplant patients? And then I guess the secondary question would be, does Viagra or drugs like that override those negative effects?
So outside of chemotherapy, we've talked enough about chemotherapy, and not specific to the transplant population, the two classes of drugs that tend to have the biggest negative effect, the amount of the effect is actually pretty small. But compared to all of the medications, the biggest effect are some blood pressure medications, beta blockers, and diuretics. And then antidepressant medications. So Lexapro, Celexa, Prozac, Zoloft, Paxil are classic drugs for reducing libido, delaying orgasm, and reducing erection function. Okay? However, if you come in and you say, I started drug X, and I got a problem, 2 weeks later, we'll try and manipulate your drug. Not always does all of a sudden the problem evaporate. Okay? So sometimes even though you're on a blood pressure medication, it's the blood pressure problem, not the medication, that's causing the problem. Because if you have high blood pressure, you have vascular disease. If you have vascular disease, there are blood flow problems in the penis likely. Men with high blood pressure, treated high blood pressure, 1.5 times more likely to have erection problems. Men with high cholesterol, treated high cholesterol, 1.5 times more likely to have erection problems. Okay? Not always related to the medication. It might be the underlying disease, the vascular disease. Yeah. Any other questions? Don't be shy. Yes. It's always the women are so much better at this than the guys. It's remarkable.
2 questions. 1, do you have a business card? And 2, do you take Medicare?
I don't have a business card. Memorial takes Medicare. Yeah, Memorial takes, I don't know how many insurances we take. We don't take a lot of insurances, but Medicare is one of them. Yeah, yeah. But I'm not the only person who does this for a living. I mean, Hossein Sadeghi at Hackensack, Mike LaSalle to St. Barnabas, Joe Luca at NYU, Doran Stemper, Beth Israel. There's about 10 in the general area, people who do what I do for a living.
In that case, is there anyone that you recommend at HUMC?
Where?
Hackensack University.
Yeah, Hossein Sadeghi is there. Hossein Sadeghi, S-A-D-E-G-H-I. Hossein is fellowship trained. He's a urologist who specializes in andrology, just like I do.
S-A-D...
E-G-H-I.
E-G-H-I.
Sadeghi. Hossein Sadeghi. And he's the current secretary of the Sexual Medicine Society of North America. He lectures, he publishes. He's a very, very nice physician, and he's very competent in this area, more than capable of taking care of you. It's my pleasure.
Thank you. So my name is Terry, and I'm 1.5 years post-autologous transplant for multiple myeloma. So I'm sure it's no surprise to you. By the way, I did enjoy your presentation tremendously. But I'm sure it's no surprise to you that what you've described is right in line with my experience. My oncologist referred me to an endocrinologist. I had low T. It's been treated with androgel, and it's back to within normal levels now. So based on what you told me, it sounds like a urologist is my next port of call. And so that's, I'm sure that's right, but if it's not right, let me know. And I did have a follow-up question to that.
So let me just address that first, Terry. So I'm not saying that endocrinologists can't deal with low testosterone. If you're put on a gel and your testosterone level returns to normal and your symptoms improve, then I think you're adequately treated. Endocrinologists are, I'll use the word nervous, more nervous than urologists are when it comes to guys with prostate enlargement, for example, etc. And they'll shy away from using testosterone. It's not that urologists are cavalier, but it's that we're completely comfortable managing your prostate problems that may be related to testosterone. So I think if you're adequately treated, I wouldn't change.
Good. And then the follow-up question, would you put Cymbalta in that same category with those other drugs that can affect the ED situation?
They can all affect ED. The further you get away from Prozac, however, the less effect they have. So Lexapro will have less effects on your sexual function than Prozac, okay? Effexor, Cymbalta, the third generation SSRIs is the class of drug. The third generation drugs are less likely, they're more specific. But yes, it's listed on all of them that they can cause problems. The most common problem is low libido. The next common problem is delayed orgasm. That's why these drugs are used for premature ejaculation. Okay, so we use Prozac now to treat men with terrible, who have very problematic and bothersome premature ejaculation. We don't use Cymbalta because it's not as effective. And then the last sexual dysfunction really is erectile dysfunction. Okay, it's my pleasure. Anything else? I'm going to hang around here. Yes. Don't be shy. Please stand up. Listen, this is all I do for a living. There's probably no question you can ask me that I haven't been asked before. So.
Yeah, thank you for this program. I really enjoy this section. I have a question concerning nutrition. What is the good food to eat to enhance sexual preference? And also, how do you know there's a low testosterone level in your spouse?
How do you know that your spouse have low testosterone?
Right, even though you enjoy the...
The definitive way is to get a blood test done.
Oh.
The symptoms that he might exhibit that should make you say, honey, you should go get your testosterone level checked, or if he's napping more often in the afternoon. Afternoon fatigue, classic example. Decreased endurance, okay? We used to go for 3-mile walks. He gets exhausted after 1.5 miles now. Irritability. He's always cranky, but he's much crankier than he used to be, okay? That's definitely, there are 3 very important symptoms, okay? If you walk around and you look at men who have what's called central obesity, their legs are small, their arms are small, but right in the middle, they've got a pot belly, there's a very high likelihood they have low testosterone. Low testosterone causes visceral fat deposition inside the belly, not under the skin, inside the belly, okay? And that's why it's associated with diabetes, because that's the fat that leads you or predisposes you to developing diabetes. So if you see those, it wouldn't be unreasonable to say, honey, maybe you should get your testosterone level checked. If you're going to do that, before 10 o'clock in the morning, you do not need to fast. Okay? It's nothing to do with food, it's not cholesterol, it's not a sugar level, it's just highest in the morning, lowest in the afternoon. You asked, the first question I didn't quite get. There was something in there about sexual preference.
Yes, about the food.
It was what?
What kind of food? Nutrition.
Food.
Yes.
There is no food. What's good for your penis, what's good for your heart is good for your penis. Right? Look after your blood pressure. Look after your cholesterol. Monitor your sugar. Exercise. Reduce your stress if that's possible in the 21st century. Right? Those things are good for your blood vessels and your heart. Your penis is a big blood vessel. All right? But there is no one particular nutritional compound or supplement that's all of a sudden going to make you better. It's not zinc, it's not selenium, it's not a Venus sativa, Pteris terribilis, ginkgo biloba, yohimbine. It's none of those things that you see advertised on TV. Okay? They're just selling you products that don't work. So I'm going to stay around for another 10 or 15 minutes. If you have a question that you would like to ask me privately, thank you very much.
Thank you.